There's a, yes, we did it 2 out already.
Yeah,
So,
it worked great. It's a really nice thing to have. It's really nice to know that I'm going to get reimbursed. And I thought it worked very
Do you have your check yet?
Huh?
Do you have your check yet?
And some of the flight was paid through Tangerine, so it's really simple that way.
Yeah.
And then I just have some stuff to send today. I just got back.
Good. Well, I was just hoping that the process would really work, because it doesn't work until you have finally got your check. Great. Thank you very much for your help, sir. So I've decided to broaden my talk a little bit today, and to talk not only about joints, but to talk a little about sports, for those of you who may be interested in that. The basis for this talk was a talk I gave at the British Association for Sports Science a couple of months ago, and I have put into it a little more about the knee sensors, and I bought knee sensors to show you. So I'm actually going to talk about remote monitoring in general. And this very much picks up on the discussion that you just had about outcomes, because I believe that the way we have measured outcomes for the last 20 years, we will look back on it soon and say, how did we ever think we knew what the patient was doing by just having them fill out paper and pencil form? And I think that it won't be long before we are instrumenting our patients post-surgery, and that we will be getting updates as often as we want them, probably more data than we want, but hopefully it'll be capsulized so that we can get the data that tells us essential information about how the patient is performing. And I stress that that is likely to be very different from what the patient is saying on some of the so-called validated inventories. I don't know that for a fact yet, but I hypothesize that that is the case. So let's have a brief look through. First of all, disclosures. So I own equity in Joint Metrics Medical, a company which we have spun off with the help of C4C, and I could talk about that for quite some time too, but better offline for anybody who's interested in it. Very good experience, really. We are in the process of developing a number of different ways of monitoring outcomes. I got a lot of people to thank for various aspects of this talk, and there they all are. On the knee work, I work with Dr. Paul Manor. He's in the OR today and can't be here. Now, I think it would be fair to characterize biomechanics research on gait over the last 100 years as with this cartoon. Basically, we load down the patient with as much instrumentation as we can possibly find, and we hook them up to various computers. We perhaps have them walk on the treadmill, and then we say to them, just walk normally. And in the lab, that's how the majority of data that has now found its way into the literature about how people move and what the gait patterns are. And I would suggest that by studying people under these sort of situations, we are really not learning what people do in their everyday lives. And that could also be said that when we see a patient in clinic and we look at their, let's say, range of motion in the knee joint, which I'll be getting to in a little while, the fact that we can move the joint through a given range of motion absolutely doesn't mean that the patient is using that range of motion and choosing to use that range of motion during the day. And I'll show you a couple of examples where hopefully that will be apparent. I think we better take it out, Jason. It's not doing what it should be. Let's give it one more try. Yes, now it's good. Sorry. So I'm going to talk to you a little bit about monitoring technology, how it works. I'm going to talk to you a little bit about how our work in space got us going on technology. A little bit of sports medicine about monitoring impact in women distance runners. And finally on to monitoring patients after TKA. I'm going to talk a little bit about a very interesting topic called classification analysis, which enables us to find out what a patient is, what activity they're actually doing And then I'll talk about commercial sensors. I'm sure you've seen these commercial sensors popping up all over the place. There are many, many versions, and talk a little bit about the future. So if we think about body-mounted sensor technology, the primary variables that you can measure, you can choose them from this menu here and many more. The most common one is the measurement of acceleration. Almost all of the commercial devices that I will show you, Fitbit and other devices, they are only based on an acceleration measurement. Now, the secondary variables that are used is people calculate other things from these primary variables. And the big one, of course, is steps. We have lived on steps for the last 10 years, 20 years. The Seattle Activity Monitor, the Fitbit monitor, they actually are step measuring devices. And that's very interesting in some regards. But from an orthopedic point of view, it really doesn't tell us how those steps were made. Were those steps made with a total range of knee motion of 20 degrees, or were they made with 80 degrees? Could be very different, and we shall never know using the conventional devices. Now, other features that you can get in these devices include connectivity to other devices you might have in your home. For example, many of the commercial activity monitors will link to a bathroom scale, so that when you get on it, you weigh yourself, it goes into your log, and you've got your activity, your log. They have dietary monitoring. That is almost entirely hand-entered, and who's going to do that for a long while? They allow competition, which is a big feature. So if you've got a Fitbit and I've got a Fitbit, we can hook up on Fitbit social networking, and you and I can compete with each other to see who is doing most activity in a given period. They also, of course, have feedback and reporting, and I shall dwell on that one because the device for the knee is meant to provide the care team with a brief summary of how the patient is doing and how they're using their knee. Now, first, you have sensors that are self-contained packages. That's one class. They have a sensor, a battery, a memory, and a display. An example of that would be a traditional pedometer. The data can't go anywhere. It simply shows on a display, and in this case, it just counts how many steps you've done a day. The next class of devices I would call a store and forward paradigm, and that is where they have some form of communications, like a Bluetooth low energy radio, and having collected the data, then they ship them to a handheld device, such as a tablet, an iPhone, which also has a Bluetooth radio, and then there is an app, and I'll show you a couple of apps for that, and you can report on your app things that you measured on your sensor. Now, if you add to that cellular service and wireless, then you've got a web interface. You don't just have an app on your phone, but you have a web interface. And then the software can really develop, and you can do the things that I mentioned, like sharing and competing. A second, somewhat underutilized aspect are feedback paradigms, where you have all the things that we just saw, where the information was flowing from the subject to the computer, but if you use the flow in the other direction, of course, all the communication that sent the data to the computer is bidirectional. And so there are many opportunities that you have for sending data back to the subject, as long as they have a display. And so, for example, the app can go to the handheld to the display, or you can do another kind of paradigm where you stream the data. And this is a very interesting one because it allows supervised physical activity. So, for example, let's supposing you have a patient in therapy, the physical therapist could reasonably check in with the patient once a week and say, now, let me see you doing that exercise. And when I say see, I mean what the sensor sees. And so you could actually get information back about whether the patient's doing the activity right, what exact range of motion they're going through, what frequency they're doing the exercise with, and so on. Now, the various reporting paradigms are, you can also, of course, insert information into the electronic medical record. So you could, at your leisure, check in on one of your patients to see what they have done for the last week in a very summarized and quick manner. Another possibility is physician notification. If the sensor and the associated software detects something that you really ought to know about, patient's not exercising, patient's got very limited range of motion, patient's sleeping all day, because we can look at things like that, then we can do more immediate notification than just sticking something in the electronic medical record. You could get a text message, or you could get a page alert or something like that. Now, we actually started remote monitoring on the space station, which is reasonably remote. It's sort of 200 miles away, but the complexity of doing the studies there are pretty high. We did a series of measurements on the ISS where we measured a day in the life of the lower extremities. We measured joint motion, muscle activity, foot forces, and before and after the flight, we measured some DEXA and CT and MR, and we were able to try and correlate the loss in musculoskeletal function that occurred in this really unique activity and environment. Now, our paradigm was store and forward, but it was a little more evolved store and forward. So we go up to a TDRS satellite, down to a remote ground terminal, into Johnson Space Center, and finally to my laptop. So it was a rather convoluted store and forward. The instrumentation was extremely bulky, and here you see some of it. And here you see the astronaut in the morning, just got up, just had breakfast, putting in the sensors into his shoes. He's wearing the monitoring device on his body, and these are the computers and the storage devices here. So this was a very bulky and large activity, but in space it can be bulky because it doesn't really matter that it weighs anything. And here you see him actually running on the treadmill. When you run the treadmill in space, of course, you've got to be tied down or you're going to float away. But he's got sensors on the leg, all up and down, a lot of meters of cable in these biking pants. Now, from these kind of studies, we were able to see that there was some very different activity, as you would expect, on Earth and in space. Here's the same individual. This is ground reaction forces, for example, for a whole day in Houston, and this is ground reaction forces for a whole day in space. You can see that this is basically a barren desert of forces here, apart from a little exercise period at the end of the day where there was a resistance exercise session and a brief treadmill walk and run. So we collected on 4 crew members. We were able to show that this notion that you see on this website from the CSA, that astronauts who live in space are required to exercise for 2 hours a day, that's absolutely false. They have a 2-hour period to exercise, but and here it is, you see, this is a typical short-term daily plan for an astronaut, and there are exercise modalities there, but when we used the record to see how long people exercise, what we found was that out of a total period set aside for exercise of 146 minutes, they were only loaded for 43 minutes. So all of the housekeeping of setting up the exercise, getting dressed, breaking it down. You're in the middle of exercise when you get a call that some alarm's going off and you have to stop. You have to go and tend to somebody's experiment. It ended up that these people really don't load very much at all, and only 29% of their actual activity period is loaded. Now, we found this from remote sensing. It would have been, you would have think, reasonably obvious that NASA, who thought they were getting 2 hours of exercise, really weren't, but it took remote sensing to find it out. So that's the first component of exercise intensity. You've got duration and loading. And the loading magnitude was only, if we look at it, this is a typical ground reaction force that you see on Earth. The forces were actually extremely low compared to those on Earth. The blue forces are from running on Earth. The red forces are from running on the space station. So you can see that not only was the duration too short, but the magnitude was too short. And so this really contributed to the spaceflight osteopenia that is a very significant thing for people who go into space. Now, the knee angle measurements were actually the germ for what we are now doing in postoperative patients. And here you see a complete day, just the raw data. Obviously, no one's going to thank you for the raw data, but I'll show you the analysis here. If you look at the histogram of the flexion angle on this axis versus the number of cycles on Earth, you can see that we typically are clustered around either having a straight knee or a flexed knee. But you can see in space it's totally different. There is only one distribution, where a unimodal distribution, where you tend to take this space posture where you hang like this. That this is the way you are for most of the day with slightly flexed knees. So this experiment where we showed that the loads are reduced, the loading's less than anticipated, the daily loads are insufficient to main bone, that these factors contributed to musculoskeletal loss, this actually led us to the idea of monitoring knee joint activity on Earth. I should add that we have also followed that up with some 84-day bed rest studies, which I'm not going to talk about today. So a brief diversion into monitoring in sport before we get on to knees. As you know, women distance runners are predisposed to lower extremity stress injuries much greater than men are. And the reasons are not exactly known, but I'm talking about tibial stress fractures, tibial stress responses, femoral stress fractures, pelvic stress fractures. And it's a reasonable hypothesis, and I have to say a hypothesis because there is no prospective data yet to show this. It is a reasonable hypothesis that elevated leg shock elevates the risk for stress injuries. So if you strike the ground with a harder impact and you send a stress wave, a shock wave up your legs, I think it's a good working hypothesis that that's generally something you'd like to see reduced in athletes who are doing repetitive stress, such as distance runners. And so we have a paradigm where on the ankle of this runner, we have a small sensor. It's a sensor that has 3 axes of acceleration, 3 axes of gyros to tell angular velocity. When she runs on the treadmill, it's got a Bluetooth radio. We have an app on a smartphone so that we can get our smartphone out and we can measure the tibial shock from runners who are on the treadmill. We can also capture it on the Mac as well. So the paradigm here is streaming. We either stream to the phone or Steve Jobs will be pleased. We're streaming to a Mac. There's a lot of literature on tibial shock, but the only retrospective study is this one, Crowell and Davis, who have looked at retrospectively people who had tibial stress fractures. They have found them to have somewhat higher axial shock. Now, I want to define that because that's going to be pretty important in the things that I'm going to say. The axial shock would be the shock that wherever the tibia is, it's the shock that is up and down the axis. And for the most part, that's all people have looked at. And I think that has led to some interesting mistakes in the literature. Tibial accelerometry in the literature only generally refers to the axial component. The accelerometers have been very light. Ours are a bit heavier. And typical peak Gs that you measure are between 5 and 9 Gs. So you can measure 5 to 9 Gs of acceleration on the tibia. Now, it's also been shown that runners can voluntarily reduce the axial component of peak shock, which is interesting. So there are some training paradigms, which I'll mention to you, where you can train runners to reduce their shock. Now, here's the size of the sensor next to an iPhone. It's what's known as an AMU, an acceleration monitoring unit. We won't go into the details too much. We just wrap it on with a Velcro strap onto the anterior tibial border. And we've looked at 32 in the first experiment, 32 women distance runners. They're all training for a race. They're not the sort of competitive marathon runners, but they're very typical of the kind of runners you might see at a sports medicine clinic who are running maybe 25, 30 miles a week and have got some injuries that they're keeping them from doing what they want. And in this experiment, they ran in their preferred shoes. Now, here's a typical raw signal. This is what's the force under the feet, and this is about 2.5 body weight. And this is the acceleration at the tibia coincident with foot strike. And this has a magnitude in this person of about 7.5 G. Now, in passing, I should mention that this peak of this configuration of the force under the foot in running is typical of a rear foot strike, when somebody comes in and strikes with the rear foot. There are people in sports medicine clinics, and one of them is a very well-known individual who is a former doctoral student of mine, that when individuals come in with a tibial stress fracture and they are rear foot strikers, that is, they strike with the rear foot, they are actually trying to change them into more flat foot strikers, based on the fact that there is a transient in the ground reaction force, and that the tibial shock appears, the axial component appeared in early experiments to be smaller in people who don't strike on the rear foot. Well, our experiments have shown, I'm going to pass that by, that there are huge differences in people between the tibial shock. So this is our lowest runner with a shock of 4 Gs. This is our heaviest striker with an impact of 10 Gs. So a remarkable range in a group of people. You don't see this in any other variable, but when you measure the leg shock, some women have 2.5 times greater leg shock than others. And so they seem to be really good candidates for varying their pattern. So what we have found, though, is because our sensor has more than one component, axial and the shear component, the front-back component, we found that if you change somebody's running pattern just based on the tibial axial shock, then you actually may be increasing their overall tibial shock. And I've got a diagram here I want to show you, this one. So this is the acceleration vector. You can see the foot here striking, and this is the acceleration vector in somebody who is striking with the rear foot. This is the acceleration vector in somebody striking with the forefoot. Now, while it's true that the forefoot striker, if you project it to the vertical axis, has got a slightly lower axial component, you can see that they have a dramatically bigger total component. And so I think this is a good example where people haven't monitored the whole of the mechanics of a particular limb and have come to the really the wrong conclusion. So I'm going to buzz by those, and I've just mentioned to you that we have a paradigm. Some of you may have seen it at the demo at the open house at the Sports Medicine Clinic last week, where the runner actually looks at their tibial shock on a screen in front of them. And these are the results from Crowell and Davis experiment. This was the pre-test, and this was the post-test axial tibial shock. And so voluntarily, the runner can change their pattern to reduce their tibial shock. And we believe this may have a place, if you measure the right things, for injured runners who are chronically injured and who happen to be in that group that has high tibial shocks. And it's a very easy measurement to make, in contrast to all of the equipment I showed you in the space experiment. This is a single sensor and an app on an iPhone. So we are just talking with sports medicine about perhaps trying to introduce this into the clinic for a group of people who may have a need for it. All right, let's get to knee joint replacement. As you know, there are a lot of knee replacements. I mentioned to you I gave this talk in the UK a month ago, and in the UK there's 70,000 knee replacements a year. Multiply that by 10 for the knee replacements in this country. So there's a lot of people getting knees, and there's going to be more people getting knees. I've got 600,000. So there's been a 7 times increase in knee replacements in the last 30 years. Interestingly, even though we tend to think of knees as being very successful, only 50% of knee replacement patients actually return to a sport or recreation after they have had their surgery. And the goal of many patients is to get back to a prior level of activity, but the data tends to suggest that that's not happening. It's also relevant that the average US hospital patient stay is 3.5 days. And so the last time that you or the PA possibly, or certainly you, will see the patient is at that 3-point day mark. And there are, depending upon the practice that the patient is in, there are not a lot of encounters with the provider after that. So there's a great possibility that, particularly with the pressure, the downward pressure on physical therapy, where there's not perhaps depending upon the patient's insurance, there's not a long course of physical therapy. There's a distinct possibility that some of these patients could fall by the wayside. 60% are discharged to home. And they could fall by the wayside with a less than satisfactory outcome that's going to come back perhaps for manipulation because of a restricted range of flexion, or the patient is simply accepting that they haven't got the range of motion they hoped for, because each patient has their own expectation about what they're going to get from the surgery. It's been shown in a number of studies that early intervention for post-op complications can prevent readmission. And I have the list of references should anybody want them. So that if you detect a patient who at 3 weeks is simply not developing the range of motion, then you can intervene at that point, and that's the most successful as far as preventing readmission is concerned. And of course, this morning, preventing readmission is becoming a much more important issue, because no one's going to pay for this readmission except for the medical center itself. And back to the point that I mentioned earlier, that subjective reporting by patients likely fails to capture objective real-life function. So let me talk to you about the paradigm of our knee monitoring. It's a store and forward paradigm. We have an app and we do reporting. And I'm going to pass this around. So this is the knee sensor. The business end is up the top here. Nothing is in the bottom except a block which holds the end of an angle sensor. So the patient wears this on their knee. It's those Velcro straps that they cut to length that keep it in place on the knee. The battery is sufficient to keep the monitor going for at least 16 hours. That's all the memory we have at the moment. When they come back to me in FedEx, which is how we use them at the moment, they're still ticking. And so we've got much more battery than we need. So there's the sensor. Pass it around. Now, we also have an app. And one of the purposes here is to try and provide data from the patient subjectively that's the same as you would ask them during an office visit. So I'm going to start the app here. I'll pass it around. I'll pass 2 rounds. You can go forward and backwards. You have to answer the first question, obviously, before you go backwards. But don't go as far forward when it says it's ready to send the data. I'll tell you about that later. Looks like we lost it. So the questions are the typical questions you would ask in the clinic. They are, let's see here. Uh-oh, AT&T wants to update me. Stop that. Always a bad thing. I'm afraid they already started, so it'll just be one fun. So The paradigm is this, that in the morning, on the day of monitoring, and we don't monitor every day, we're only going to ask the patient to monitor possibly once a week. The patient will put the sensor on in the morning, and they'll wear it the whole day. At the end of the day, they'll run the app on the phone, answer the questions, and then they'll press the button which will upload the data to our servers. And that generates a series of analysis programs that run. I just want to show you that.
You're getting a phone call.
Don't answer it. It's probably AT&T saying we'd like to update you. All of the things we were doing in space, the idea of this is to shrink it down so that in one sensor and an app, we can do the same things. So you have the sensor in your hands, you see the app, and here you see a web-based application to report to the clinician the findings of the day's study. And that feedback is pretty quick. And I want to go over briefly the elements of the report. So the report, first of all, gives you information about the patient in the header. And there are a series of alerts which are things that I mentioned that you really need to know. So these are pretty hard to read, but the range of motion in this patient has been reduced. The walking distance has decreased. And the patient was not detected to be performing any therapeutic exercises. Well, those alerts imply that there's a lot of intelligence going on behind the scenes in the analysis of these data. And so here are the results of the patient's subjective report. Here are the measured knee function, and I'll show you some of those. Those are things like range of motion used, the number of knee joint excursions during the day. And down here is an activity profile, which in this particular report, on 7 different activities, lying, standing, sitting, walking, riding an exercise bike, doing therapeutic exercise, this ring chart shows you what the patient was doing. And in this case, they spend most of the time lying down. They spent this part of the time sitting down. And only here were brief periods of activity during the day. Now, how do we know that? Well, what we do is we operate on the data stream with what's called a classification analysis, where we teach the program what a patient who is walking actually looks like in terms of the signals that we're measuring on the sensor. So we have a variety of signals, as I described, and these classification networks are really pretty intelligent. It's a little bit like a development of neural networks, where there are no rules. You just say, figure it out. This is what the signal looks like in this activity. Find out which signals to use, what limits to set, how you build the tree, and finally, in normal subjects, we get down to a 95% prediction of the actual activity that the patient was doing within the menu of activities that we've actually got. Here's a blow-up and a few other things. See, here you can see that those are the alerts. Here's the sector of joint range that the patient was using, from 5 extension to 66 flexion, that they had 420 excursions an hour, and the mean excursion was only 16 degrees. Here's the activity profile, and here's the data from the patient questions on the app that you're looking at. And by the way, I do need the phone back, in case anybody's thinking they'd like a Galaxy phone. And here's the trending you see. So the pain was trending horizontally, as was the satisfaction, but the range of motion was decreased, and the activity was decreased. So this report is a compromise between all the activity we have and the time you have to read it. It may also have gone a little far in the sense that this is probably going to take 30 seconds to scan. And whether that 30-second scan can fit into the day of somebody who's watching this patient remains to be seen, and more importantly, can they charge for it? So these issues are still to be answered, because obviously, unless it either proves very useful in preventing readmission, very useful in documenting outcomes quantitatively, or if it's reimbursed extremely well. Any one of those three things are going to be drivers for the adoption of such monitoring. I want to show you a couple of results. I'm going to actually pass by this subject, and I'm going to show you the results from a 53-year-old woman who had a bilateral knee replacement, and we're looking at her right side, and a 71-year-old female, and she had a unilateral. Now, here is the raw data, and this is something you will never see, but I'm showing it to you just to know what's sort of behind the activity. What this is knee angle as a function of time. Full extension is this line here. These are 10-degree increments, 10, 20, 30, 40, 50. You can see, I'm sorry, that's wrong. These are 20-degree increments, 20, 40, 60, 80, 100. We had approximately 4.5 hours monitoring from her, and then she took it off. And of course, that's always an issue. The patient has to wear the sensor for you to get data. But in that 4.5 hour period, the patient did 238 flexions per hour, and her maximum flexion was 82. And this was on day 21 following her surgery. So she was already 3 weeks out. Now, I think this is already new data in the sense that if I'd have asked you at the beginning, so how much does a patient with 3 weeks typically use their knee? You couldn't have answered me, and I couldn't have answered it without some of the measurements that we're now learning. Now, here she is 120 days at 120 days, same subject. The scale is the same. And you notice that what happened here is she no longer has the extension limitation, so she's now right down to full extension. But you can see that her used range of flexion has not changed at all. It was 82 before, and it's 78 now. Now, this is a typical example of a patient who might come into the clinic, and you look at her range of motion, and you find out, yes, she has indeed got 100 degrees of flexion and full extension. But you can see that not once during the day, because we're capturing every single flexion, and this time we have a whole lot more data. This is about 10 hours out here. She worked for 10 hours. So you can see that as far as certainly her activity in terms of the number of flexions has gone up, and she has increased her range of full extension, but she is not choosing to use a flexion range greater than 78 degrees. Now, in contrast, here is the patient who's now 54, who had the bilateral TKA, and you see that at day 15, she was already very active. She had a rate of 581 flexions per hour. She had a maximum flexion used of 80 degrees, and you can see she had an extension limitation. She wasn't down on the line here. And this is at day 15. By day 120, same scale, except for time. Time scale is different. She was doing about the same number of flexions per hour, because she was very active at day 15. But now you can see two important things have happened. That she now is using up to 117 degrees, and she has full extension. So you see these two patients offer you a perspective on progress. The one patient is using a limited range of motion. She's not very active. And this patient is active even though she's bilateral. She's active right away from week 2. And she, by day 120, is using a very typical normal range of motion. Another example here is 3 patients where you see they all, this is the measuring period here in weeks. They all achieved full extension, but you can see that they did not all achieve flexion, that this patient continued to increase their range of motion up to week 15, whereas these patients seem stuck around 80 or below. So I would propose that this kind of information is useful to know therapeutically useful, and would allow the care team to modify their program to reflect the individual needs of the given patients. Just a brief word about activity classification. This is what a classification tree looks like, where this is a sort of a graphical representation of a computer program. At every one of these junctions, a question is made about one of the signals. Is the acceleration greater or less than this? Is the flexion greater or less than this? Is the variance greater or less than this? And you eventually make your way down the tree, and there are multiple ways to get the same answer, and you achieve the final activity recognition with a given degree of certainty. And you can see that some of them are easy to get to. You only need to ask 2 questions to find out whether the patient is cycling. You only need to ask 2 questions, 2 mathematical questions, to see whether they're doing their exercise. But it's more complicated when you get down here to some of these other activities. All right, let me finish by just talking a little bit about what body-mounted sensors you can find in the marketplace and what do they look like. What I think has happened here is that we've seen what some people have called the gamification of fitness, that we've turned fitness into one big game, and there's somewhat of a difference of opinion as to whether it's worked to actually motivate people. But just look at the size of this market. Whereas nearly 1 billion Nintendo games have been sold, almost 100 million Wii Sports units have been sold, and 43 million Wii Fit Plus units have been sold. So there is a lot of people doing these things. There are, interestingly, lots of apps that don't need any sensors other than the sensors that are in the smartphone. Your smartphone's packed full with all kinds of sensors. There's gyros, there's a gravity sensor, there is acceleration sensors, and the only problem with using them is that they're not rigidly attached to your body. But nonetheless, there's apps where you can just put this in your pocket and report at the end of the day an estimate of what you've done, only in terms of steps. And Runkeeper, iTreadmill, and iSteps are apps that you can get for your phone that actually do that for you. Some of them have onboard acceleration and location sensing. This is the Nike Fuel Band. It is only an accelerometer, and there's nothing else to it. There's just a triaxial accelerometer in that band, and it has got an algorithm which does some classification as I described to you. And really with these devices, it's all in the software. They're all almost identical inside. It's just how they manage the software. Interestingly, one of the tech writers found that with that fuel band, because of course Nike has a fuel points system where they take it, that you actually got more points for eating a slice of pizza than walking up the stairs, which kind of shows you the dangers of using classification. Jawbone is another one. Jawbone Up is their latest activity, which again is only an accelerometer, and it's all in the software. It's got all of those features that I mentioned to you earlier. It's got competition, it's got a community, it's got dietary tracking, and so on. The Fitbit is another one that is just an accelerometer, and you can clip this on various parts of the body, and it has all of those features in the same way too. Basis band is slightly different because it also attempts to predict energy cost. It has a temperature sensor, it has galvanic skin response sensor on the back of the watch, and so it tries to do more with energy cost, and they do sleep tracking too, by the way. So what's a consumer going to do? They're going to get one of each to wear them. I think that what we're going to see is that we're going to see integration. The Google Glass, for example, is a perfect partner for our feedback display. So you could imagine somebody could be running that you wanted to change the pattern of motion. They could be getting the feedback on their Google Glass as to what they should be doing and changing their pattern, as long as they're not running into a wall while they're concentrating on their feedback demonstration. But it's sure going to happen. This is in development. A interaxon Muse brain sensing, which actually measures EEG and purports to be able to make some sense of that signal for runner feedback. And I think that we're going to see in the future a very different relationship with technology. The sensor could be a partner, it could be an evaluator, but it could also be a spy, and it shouldn't look too much like an ankle bracelet, else people are not going to wear it either. All right, that's it. That's a brief run through body-mounted sensors for sport rehabilitation. So, any questions? Amy?
Your pre-post, did you because you said you did 1 day of activity measurement?
We did.
So how did you get like the patient's decreased range of motion? Was it from their beginning day measurement?
Oh, so we have not yet looked at pre-surgical monitoring. We've got just a couple of patients pre-surgical. That offers, I'm glad you raised that, that offers a very interesting thing. As I think you know, qualification for a joint replacement at the moment is really a pretty simple thing. You simply write a letter and you say, this patient has failed NSAIDs, they failed Synvisc, they're ready for a knee replacement. It's really easy. Nobody asks you what their exact motion limitation is, what their levels of pain are, although you usually write it in the letter. But I think we're going to see a change in that. And I think that monitoring may be a component of pre-surgical qualification. Now, of course, it'd be easy to cheat, and the patient could just lie in bed for a week during the monitoring, but there are ways of getting over that. So I think that monitoring patients before they have qualified for a joint replacement is really another interesting possibility that may happen. Kenny?
Well, I just think this is really great and important, and I just presented some stuff at the tumor meeting about using this, and I just hope people realize like the difference between a gait analysis in a lab, which is kind of like in vitro, versus this kind of in vivo, seeing people do things in their real environment. But I wonder something, there's a whole level of validation that's going to have to go along with this, because you're challenging some assumptions, because we think people can't go downstairs without flexing their knee like 100 or 110 degrees, but clearly some of
These people are navigating stairs.
And so there's a lot of work that looks like needs to be done in the future.
You're absolutely right. I mean, you can find papers in the literature that specifically say what range of motion you need for a given activity.
Yeah.
Now I think we're going to see that people are actually managing to do these activities with lesser range of motion. Bruce?
Yeah, I mean, your original statement is a little trite. I think what we've learned in the last 10 years of research is we need patient-generated outcome information. And it's the same for measuring motion. If you don't match that to the patient's functional perception of what they've gained or lost. So for instance, there is some evidence to suggest that for a female, loss of 10 to 15 degrees of flexion is more important than in a male. And in a male, loss of extension is more important than in a female. So you've got to match the patient's perception of their disability with the measurements that they have. So I think we've learned things from our research in the last 10 years, and just giving range of motion data without some patient correlated perception of their own function is equally as silo orientated.
I think.
Okay,
I just think like the coolest thing with your app is that you could actually do a patient-reported outcome measure right along with your data, and not only be able to correlate it, but get the full picture. Like I agree.
For
I
instance,
doubt that this is the
in
end
many
of
countries,
patient-reported
the
outcome.
Oxford 12 knee score is their measure for whether you qualify for a joint replacement.
Yeah.
And it has some inherent patient assessment of their disability and loss of motion. If you match that specifically to the data that you collect, you can say, well, in fact, this part of what we collect correlates with how the patients feel they are disabled. And that's what the insurers and the keepers of healthcare want to know.
Yeah, so a lot of things you brought up here. So which, I missed which part you think is trite. Which part is trite?
Well, saying that we will look back on our last 10 years of patient assessment and research and say we collected all the wrong things.
Okay, no, I wasn't meaning to mean that. Obviously, I'm making the point that I think there may be a disconnect between knee society score, Oxford knee score, and what the patient is actually doing, and it doesn't give you much insight into what they're actually doing, and I still stand by that. So do you think doing an Oxford knee score tells you what the patient's doing in their daily life?
I think doing an Oxford knee score is better in telling how the patient is disabled in their daily life than what I measure in the clinic. I can measure their range of motion in the clinic. That means nothing if the patient says, Doc, I can do everything I want to do.
We're in agreement. And then I would say the third thing is that measuring what the patient's actually doing is better than either of those two things.
Well, I as a clinician, I don't necessarily.
It's
agree
9
with
hours.
that. Because you also, it's the pre-measure too. If I've changed the pace, for instance, here's the patients with dramatic multidirectional instability find their motion and instability disabling. And if you measure their scores and do an arthrodesis on that patient, so you fuse their joint, their perception is they are way better than they were before they had a hopelessly unstable
But I think
joint.
you've chosen a case that's very distant from the application that I'm showing. These people have come to get increased range of motion, to get improved pain scores, and to increase their functional capability to do things in their life that they have lost.
That's the thing, they want functional improvement, and
Yeah.
that may or may not be related to certain aspects of their range of motion. And we don't know that yet.
Well,
We don't
I
know.
don't think we're so far off, but I think that you're arguing more that the patient-centered information is really an important component, and I'm saying that let's not throw it away, but let's add to it knowledge of what the patient's actually doing.
I think they're equally important, and then we will learn which part of the data you collect truly means more to the patient.
And we'll learn which part of the data you collect is truly meaningful in the patient's
Probably
outcome.
meaningless, I'm happy to accept it.
All right.
But that's not, the other thing I wanted to ask you was, all the money in sports, medicine, athlete tracking is in stadium-based sports and GPS tracking.
It is.
That's where it's going now. It's amazing how sophisticated their data collection systems are. How do you see this system working with or in competition to those kinds
Yeah,
of systems?
so I'm very familiar with those systems. They're basically the same sensors that I'm using on the leg shot, mounted on a harness that the patient wears during real sort of, not in play, but in practice situations.
Oh, they wear them in play now too.
Well, yes, and some of the helmet, of course, for looking at headshot. But I think that they will revolutionize the individual way athletes can be trained. I saw a magnificent presentation in England by the strength and conditioning coach of the British women's field hockey team. Over a whole year, they were monitored every single workout that they did for 365 days leading up to the Olympics, where they medaled. And it really was quite remarkable now, the level of individual assessment and evaluation that can be obtained with tracking. So I think it's quite has the potential to quite revolutionize athlete
Yeah, I think
training.
Aussie rules football has taken it to the, from what I've seen, greatest extreme. So they can tell when someone's about to injure themselves by the change in their tracking and acceleration data.
Yeah,
Which
well,
is
there's
quite
lot
a
more needs to be
big,
known.
so they pull them off when they're monitoring during a game, and when the acceleration, particularly when they're kicking, becomes disordered, then they pull them off because they know they're about to tear a hamstring.
Yeah,
That's what
I
they
think
will
there's
tell
lots
you.
of potential.
Yeah.
And many pro teams in this country are doing it, many college teams are doing it, and I think it's really going to be an interesting to see where this goes. Okay, you have things to do? Thank you.
Thank you.
Thank you.